Hi, I'm Jim Amos. I'm a CL psychiatrist, and this is a talk about acute and chronic brain injury, which is another way to think about delirium and dementia. Delirium is an acute brain injury, and by DSM-5 criteria has an acute onset, typically over hours, a fluctuating disturbance of consciousness, attention, and cognition, perceptual disturbances, including visual hallucinations, fragmented paranoid delusions, and the acute injury can persist, sometimes irreversibly. On the other hand, dementia is a chronic brain injury, and it's a persisting cognitive impairment, often progressive, with dysfunction in two or more cognitive domains and interfering with ADLs. It's now called major neurocognitive disorder. The emphasis is on a continuum of changes from normal aging to dementia, and delirium can cause dementia. Delirium and dementia are on a two-way street, both leading to bad outcomes. Delirium can lead to dementia, and dementia raises the risk for delirium along with advanced age. About 50% of critically ill patients not needing intubation and 80% of critically ill patients needing intubation will get delirious, and 25% of patients are delirious for 5 or more days. Uniformly, delirium predicts bad outcomes. It predicts higher mortality, it's linked to pulling out lines, longer hospital stays, and the longer you're delirious, the higher risk for worse cognitive impairment at 1 year. In some studies, cognitive impairment has been reported as a less desirable outcome than death. Delirium outcomes have been studied in ARDS patients, and about 70% of survivors are cognitively impaired at discharge. About 100% of them rated information about long-term cognitive outcomes up front as being important to their medical decision making. Delirium is an acute brain injury, while dementia is a chronic brain injury. Examples include Alzheimer's disease and Lewy body dementia. Alzheimer's starts with short-term recall, and long-term memory and vocabulary tend to be preserved at first. Lewy body dementia looks a lot like delirium, can be marked by visual hallucinations and Parkinsonism. Vascular dementia is marked by memory loss and executive dysfunction. Risk factors include coronary artery disease, hypertension, hyperlipidemia, and diabetes mellitus, and it tends to be preventable. It can be comorbid with Alzheimer's disease. Delirium diagnosis, according to the DSM-5, involves a disturbance in attention and an onset and development acutely over time, generally hours to days, a decrement in cognitive function, disorientation, language disturbance, and the criteria must not occur during a coma. Screening for delirium is easily done using the confusion assessment method, or the CAM, which is based on the DSM-4, and the modified Minicog test, which involves the clock drawing task. Always suspect delirium in the hospitalized demented elderly. Up to 2/3 of delirium is either not diagnosed or misdiagnosed. It's easy to identify delirium using the Minicog. See a video of the Minicog at the hyperlink below. You can also ask a patient to recite the months of the year backwards. The single question in delirium, or SQUID, can be done simply by asking a family member or friend visiting if the patient seems confused. The clinical diagnosis of dementia involves taking a history and also getting collateral history from an informant, psychiatric and neuropsychological assessments, bedside screens, including the Montreal Cognitive Assessment, labs, and neuroimaging. The table suggests ways to distinguish delirium from dementia. For example, the onset of delirium tends to be acute, while dementia, it's insidious. The level of consciousness tends to fluctuate in delirium, while it is clear until late in the course of dementia. Delirium and dementia behavioral challenge management is not always best done by pharmacologic methods. The TDA method includes tolerate, anticipate, don't agitate, and videos illustrating this approach can be seen at the links. It's always a good idea to reduce delirium risk whenever you can. Many studies show that non-pharmacologic protocols can reduce delirium incidence. It's a good idea to avoid benzodiazepines whenever possible. They tend to be an independent risk factor for delirium in ICU studies. Let's try a case, the angry 82-year-old. This 82-year-old man is admitted to the ER from a nursing home. He's had an acute change from baseline. He's not sleeping, and he's more confused and paranoid. We find he's disoriented, distractible, and has word-finding problems. And so we find that he has delirium superimposed on his dementia. Records review reveals that his Aricept was recently stopped. Benadryl started a few days ago for insomnia. He's on chronic digoxin, and he has chronic urinary incontinence. His minicog is markedly abnormal. Tests show that his albumin is low, his digoxin is subtherapeutic, his UA shows lots of white cells and a positive leukocyte esterase. So his causes of delirium are digoxin toxicity, diphenhydramine, and a urinary tract infection, primarily. Management, therefore, would be to give him an antibiotic for his UTI, hold his digoxin until the level normalizes, try something like melatonin instead of diphenhydramine for insomnia, manage his nutrition and hydration, consider restarting Aricept, and being vigilant for other contributors to delirium. These are the pertinent references. The links still work, and thanks for listening.